All right, well, thank you for coming out tonight. I hope I didn't scare too many people away by headlining this event. I appreciate the invitation. Thanks for having me. I wanted to start off by just addressing what the concern is, what the problem is for the employer who's offering insurance to their employees. And I've talked to I don't know how many employers now, and I've heard basically the same thing, but I'm interested to see if I get nods of recognition here tonight when I say how I understand the problem of the employer in offering benefits. What I hear is that we are paying one of our largest expenses. The third line item on our P&L is for insurance benefits, health insurance benefits. And yet, we're not finding that to be a value driver for our employees, and it's certainly not adding, anything to the bottom line of our company. So this expense that doesn't seem to add value also is going up every single year. And so that would be a problem for any expense on your P&L that's going up every year. But this one is special in that you have no control over it. You don't know how to reroute the funds. They just keep going up, and you don't have any control over what's happening. I am seeing some nods here. So am I way off? Is there anything I'm totally missing on what the issue is with offering benefits to employees?
It's not only are they not going up, but I don't know if my employees are getting good health care either.
Yes. Well, let me tell you a little bit about how I've experienced the other side of that problem in particular. So I have always wanted to be a physician. I saw that as the greatest opportunity I could have to actually benefit people, to help people to be healthier and happier. And as I came out of medical school, I found myself in a system that did not seem to be helping people get healthier. And I wondered why. I wondered why we weren't investing in our patients to try and help them do the things that will make their life healthier and happier. And it seemed to crystallize for me one day when an executive came to my clinic and he said, "Your clinic is doing really well. You guys almost broke even this year." And I did not understand at all what that meant. I don't know if it's obvious to you immediately what that means, but we're talking about working for a primary care clinic that is owned by a hospital system, and the executive says, yes, we lose at least 10% on all of our primary care clinics. And we're talking about an organization that you guys would recognize. I won't say their name here today, but we're talking about one of the major organizations here in town that owns hospitals and primary care clinics. And not only do they own some primary care clinics, but these hospitals have bought up most of the primary care clinics in town. The clinics that your employees are going to for their primary care, mostly here in town. So what does it mean when an organization, a hospital company, buys up all of the primary care practices and intends to lose money on those practices? You have a comment?
Were you busy? Were you seeing a lot of patients?
Yeah, so we were seeing 24, 25 patients a day in this primary care clinic. It was a successful clinic. We were also getting paid really low, compared to the market. That's probably part of why our clinic was doing well compared to the rest of their clinics. But I've since learned that this was not just true of this one organization, but all of the major hospital organizations in town lose money on their primary care. and some of them to the tune of tens of millions and maybe hundreds of millions of dollars right here in the Phoenix area, intended to be lost on primary care. So what that means to me is, and we could speculate on why these companies would be buying up all of the primary care in town if they're going to lose money on them. But what it means to me is, at the very least, we cannot say that these companies are in the business of primary preventive medicine. So when your employees take your insurance card to the doctor that is covered on their plan, they are being seen by a doctor who works for an organization who does not make money by preventing disease. And what I think that means, well, let me just ask you what you think. So now you are the CEO of this company, and I come into your office and I say, I've got a plan that I am confident will decrease hospitalizations by 30% if we just put a little bit of money into changing some protocols in the primary care clinic. So you, Mr. Hospital CEO, do you want to invest $50,000, $100,000 into a plan that will decrease hospitalizations by 30%?
Personally, I want the money.
Well, and so I know I know a couple of the CEOs of these organizations, and they are great people. They're people who love to take care of patients. They want the patients to be well taken care of. But you can't overcome that incentive. You can't put in a policy that bankrupts your organization, even if it means that it's going to help a bunch of people. So from a physician's perspective, where I was working for an organization where my best ideas to improve downstream healthcare, to improve the lives of the patients by preventing disease, will never be listened to. And that is the case of all of my friends. Just this last weekend, I went out to dinner with the friends that I trained with in residency, and they are all working for these big organizations. And they were miserable. All of them expressed misery at the job that they were doing. And they didn't seem to quite know why they were miserable. And if you're watching here tonight, my friends, I'd love to talk more with you about this, but they expressed this feeling that their work did not mean anything. It wasn't making an impact on their patients. And I felt that same thing to a degree that I was desperate. I was desperate to do something meaningful with my life. I was desperate to do some of what I thought I was going to do, which was to prevent and reverse suffering. And I was in a system that had no incentive for me to do that. In fact, was incentivized for me to fail at that job. The job that I had been preparing for 10 years or maybe 20 years to do. I was working in a system that did not allow me to do that. And that is a very rough spot for the physicians all around the country, but the ones I know personally right here in this town, they're working for organizations where they're not incentivized to help people get healthy in the way that they might be. And so now we've got this problem over here, your problem that you talked about, that you nodded your head, and your problem where you nodded your head, that we have this high cost expense on our P&L that we don't have control over and is not providing real value to us or our employees. And that problem is the same problem that I was dealing with within that system. It is, in both cases, nobody makes more money when people get healthier. So nobody's getting good service, nobody's getting high value, and that was something that needed to be fixed. So in my desperate state, I was looking around to try and figure out, well, what could I do with my life? Perhaps I could start a band and get my music career going again, or professional athletics was probably off the table by this time. but I was seriously thinking about what are my options outside of medicine, because I don't want to be stuck in a system where I am disincentivized to do what's best for the patients. And it was in that kind of desperate looking around that I found people doing what was called direct primary care. And at first blush, direct primary care did not sound very interesting to me. I heard that people were paying a membership to get better access to healthcare, which sounded to me like concierge medicine. The idea that, most of us aren't going to get good health care, but if you have a lot of extra money, you might be able to pay somebody for better health care than the normal. And that's what I thought direct primary care was when I first heard about it. Looking into it a little deeper, I found that direct primary care doesn't have to cost so much money that it prices out most of the population. In fact, there's a significant subset of the population that now receives health care in an affordable way that could not get access to health care before, because direct primary care is an affordable way of providing primary care. So we started a practice now 8 years ago, and at that time we were catering mostly to individuals who were getting access to primary care through this membership-based medicine through ARC Family Health. And the membership is around $100 a month, and it gets you access to all the visits you need, procedures that we can do in office. You also get wholesale pricing on labs and medication and imaging. And so these individuals were getting predictable, low-cost, high-value healthcare from us. And it wasn't long before employers started asking, can our employees get access to this same kind of healthcare? And the answer was, yeah. You can use direct primary care as part of your benefits package. And people have been doing that before we were doing it, although here in town we were the first and only practice for a while to be doing direct primary care. And we started getting more employers coming to us and asking us to take care of their employees. And these employers were finding that the downstream costs of their healthcare reduced dramatically when they were investing upstream in the primary care, on the primary care side of their benefits package. So that might not seem too concrete until you hear a couple of stories. Let me just tell you a couple of stories how that happens. So one story that I think is pretty common, or this kind of thing happens fairly commonly in a primary care practice, is on I believe this was a Saturday morning. I got a phone call, and because I have a relatively small patient panel, I'm able to take phone calls on Saturday mornings. So we're available to our patients, your employees potentially, 24/7. You don't want your employees going to the urgent cares where they're going to get funneled into that other system. You want them calling us. And so on this Saturday morning, I got a phone call from a young lady who was experiencing some pain in her back flank, and it sounded like she might have a kidney stone. Well, how do you manage kidney stones? In every primary care practice that I'm aware of across this town, outside of a DPC office like ours, you will be immediately sent to the emergency room every single time. I have not heard of any primary care practices managing a kidney stone outpatient, and there's reasonable historical reasons for that. The main one being that you got to have a CT scan to know, first of all, that it is a kidney stone and how big is it. And that's going to determine what you do long term. So, well, how do you get a CT scan at 11 a.m. on a Saturday? Well, most of the time, you got to go to the emergency room for that. But because of the unique incentives in direct primary care, we were able to evaluate the patient, we were able to control her pain, and get a CT scan all before noon on a Saturday morning. And turns out that stone was small enough that it did not require any kind of intervention to pass. There was a medicine that would help it pass, but it didn't require any hospitalization, no procedures or anything like that. So the CT scan cost $250. The visit with me didn't cost anything outside of the membership that was already paid by the employer. And the patient had zero out-of-pocket costs. There was no cost for either the visit or the CT scan. Contrast that with what would have happened in every single other primary care clinic that I'm aware of. An immediate visit to the emergency room, which has a baseline price of something like $3,000 for that same set of imaging and labs that were done, and could go up anywhere as high as $15,000. We've seen bills like that for things simpler than a kidney stone. So that's just one of 100 stories that show that when you have a different set of incentives, then a whole different set of possibilities show up. And our incentive as a direct primary care office is not to see how many times we can see you, is not to meet any quotas of referrals to the hospital or referrals to a specialist, and it's not to increase the amount of labs that we bill. We don't make any more money when we bill for labs. We break even on anything that we bill for. So our incentive is to make sure we're doing the best health care possible, and preferably keeping people well so they don't have to call us tomorrow. I had church the next day, so I wanted this patient to be taken care of, and she was. And she got what I think is the best care she could have possibly gotten on that day. Go ahead.
You mentioned that the stone was small.
Mm-hmm.
What if it was a larger stone? As a primary care, what do you do then if it's a larger stone that maybe not passed, maybe it needs whatever that blast them up thing is?
Yeah, I think it's technically called the blast them up thing.
Is it?
Yeah, I think you got that right on.
In our industry, that's
yeah, that's a great question, because in the event of a 13 millimeter stone, something that's unlikely to pass through without lithotripsy or some kind of procedure, then you're going to need to involve the specialist. And again, where that usually happens is through the emergency room. Well, passing a kidney stone or getting a procedure for a kidney stone is not an emergency. And in fact, it usually doesn't even happen on an emergent basis. You might get admitted to the emergency or admitted to the hospital through the emergency room in order to wait for the urologist to come and use the blast them up thing. But that's not, doesn't need to happen in the hospital. So we have had those where we arrange for outpatient recovery of the stone or lithotripsy, and they just skip the whole emergency room experience and visit, and go straight to the right care at the right place.
They do fine.
Oh yeah, yeah. So that, I hope, helps to bridge the gap a little bit between what the problem is for the employer and the problem for the medical provider, and how we can get those two things together. And I want to show a little clip here that gives some of the experience from the employer's side. So I will tee that up here.
Being in the Arizona and Southwest, we better make it spicy cleaning this show up right now. So if I get going, shut me down. I moved into this role and with a great deal of support from my executive team, and I answer directly to the owner of the company. Madison Highland Prep is a charter school, but we also have two other schools in our network, Highland Prep Academies, collectively here in Arizona and in the Metro Valley area. When I came on board, we had, basic big box insurance, but it was always, our founder's vision was every employee should have medical care they can rely on provided by the company for free. So since the inception of the organization, every employee has had paid for health, dental, vision, life by the company, and they just pay the difference to add on dependents and things like that. So 4 years into my employment, I got to be I was promoted into the person that said, here's the renewal, make it happen. And I renewed it for 2 times under that big box method. And, similar to what Christina mentioned earlier, every year I get told, all right, your rates are going up 26%, but don't worry, we've got it connect. We got it back. It's only going to go up 10%. And I would say, okay, cool. What's going to happen new? Nothing. It's the same. And I was like, why? And, they'd be like, don't worry, the plan's running great. And then come October, plan's running bad. You're out of money. Well, how did that work out? I don't know. We'll talk about it when we renew. And so we kind of got sick of that model. And employees, unfortunately, they only know what you tell them, what they come to know. They know what the mainstream insurance is like, what it's like to go to a doctor, wait for 3 weeks, 4 weeks to get an appointment, and they don't see anything of it. But that didn't sit well with me, that we keep charging people more, and we're not getting anything out of it. Our employees aren't getting anything out of it, and they don't have anything to take home to their families. And to know that this is what our people rely on when things are at their worst. You don't plan to go to the doctor. It gives you hesitancy and stress. And so when you show up and the bills are high, it's what everybody talks about. And I just couldn't accept that. So I had some pretty remarkable people push me in this direct primary care, self-insured direction. And my decision-making time frame for this was about 3 months between when we were bunching the other broker and when we were going to potentially move into something new. And I had someone tell me on the broker side, you got to make a decision. You either trust them and jump, or you stay with what you've been having. And so I took a trust fall, and that's when I met Dr. Johnson. I met David Contorno with ePowered Benefits, Gentry Harris at the Mahoney Group, and it's this and Coastal Administrative Services as well. And I found this. I became educated as I'm educating our employees. This is what this healthcare is going to do for you now. Well, what about all of these questions? I have no idea. Let me get back to you next week. And so we did it. We implemented it live. And I know David, Roger, you guys had this great idea of doing a trial run. Yeah, we just ran. And we started with, a little bit of hesitancy with how they were going to do it, but I got to present a plan where, having met Dr. Johnson, I got to tell people you have access to a doctor 24/7. You can text, you can call, you can chat, and your doctor chats back with you. Your doctor meets you at the door. And it was so disruptive to people that, what do you mean they do cardiology here? What do you mean they can do all of my labs? What do you mean they can do all of this? And it has been transformative to teachers and to the people that we work with and to their families, how that has positively impacted not just their budget, because it is significant cost savings, but their reliability on knowing that they're going to get quality care from people who are looking out for their well-being, not referring them to the next step in the diagnostic process. So that's been, and knowing DPC, getting to understand direct primary care, we're in our second year of having this. And I looked at the numbers. I've got 11 people on what we call our open access plan, where they can find their own primary care. And we've got 63 on DPC. And those are members. That doesn't include dependents. It is worked. People believe in it. And just this model of being able to see your doctor and not have to take off time from work. And when we look at from the teacher classroom angle, they don't have to leave their classroom for an entire day 3 weeks from now to go to the doctor. They can step out and call in. They can text. They can review their lab work through FaceTime. And it's been, our folks have really liked it. But I can't say that without saying the cost, how the finances have factored into this. We've been able to do really cool things with the cost savings we have. I don't run in a negative in October anymore. I end in June with a surplus. And I was like, what are we going to do with this? We increased our employee PTO. We doubled it over the course of 2 years. We've implemented a wellness day where we give people an extra free day just to go to their doctor. We've been able to do all of these other things that we didn't know that we could do. And we just keep trying to come up with new ideas and new plans with a small organization of maybe 100 employees. We then extended this to all of our part-time employees. So now full-time and part-time get full paid benefits through this because of what we've been able to do with this program. And so now we're not only changing people into believing in this, but we were able to bring on new people. Just 2 weeks ago, I talking with a member, unfortunate circumstance of the member's spouse was laid off from work. And that spouse carried the family on insurance with the exception of our member. And her response to me was, yeah, it's a tough situation. He'll find a job. You know what I'm happy about, Dustin? I get to bring all of my family onto ARC now. Let's get the life change form in. We had somebody over the summer try to go to a medical procedure, and the member got quoted $13,000 out of pocket. We don't cover your insurance. We don't cover your doctor. You got to pay out of pocket $7,000, and we'll put the rest on a credit card through our hospital network that you can pay off. And I said, give me a week. And within a week, we found a specialist in that procedure. The member's recovery time went from 6 weeks to 2 weeks, and that member has paid $0 for any of the services that they received.
Wow.
And I keep telling those
absolutely.
stories. I hear they don't come. I hear them, and so whenever we onboard new people, I'm at those meetings. I work through the plan, and I tell them these things. And I tell them, you're going to go see your doctor, and you're going to pay nothing. You're going to get an MRI, and you're going to pay nothing if you take the steerage that you get through the plan. You're going to go to the pharmacy, and I'm my own example. I haven't gone to a doctor in 8 years. I get all of my pharmacy from Mexico because I didn't want to pay $100 for an inhaler anymore. It just didn't make any sense. I have insurance. Why is this happening? So I went and saw my doctor at ARC because I'm lazy. It took me a year, but I got there. I got prescribed medications. I showed up at the pharmacy, and they're like, yeah, it's going to be $350. It's like $350? I told you it wouldn't work. And they're like, no, $3.50 for all of it. And I was like, all right, it works. And so these little things just keep coming up that we keep finding. And I'll talk to anybody that I can for however long they'll let me. Take the jump, take the trust, because it's a remarkable thing. But we can't do that without practices. I'm familiar with Ark and Dr. Johnson and his team, and it is just so fascinating for me to hear about these other direct primary cares in San Antonio and in Nevada and throughout our country, and just finding ways to open that up to more people, and hoping that some of our larger organizations that have that choice can feel that too. So it's Arizona. Sorry, I get going.
Hey! I'll tell you, it's unfortunate you're not excited about your plan.
Got to work on that.
Pretty cool. A pretty cool experience. And to see somebody, I mean, picture this, somebody in a high-level HR or CFO role being that excited about their health benefits. I mean, I only showed you part of what he said here, and Dustin is just very excited about this part of his job where he feels like he's doing something meaningful for his employees. So I hope that makes sense, that this is two sides of the same problem when we're talking about employers want to get better health care for their employees. They want to see better value for their healthcare dollars. And doctors want to provide better care than they're currently able to provide in the system. And fortunately with direct primary care, that's happening all over the city here. There's 28 employers that use our membership here in this area, but there's a growing number of direct primary cares around town and all over the country who are implementing these strategies and having this kind of positive success. So thank you so much for coming out, and I'll take any questions if you guys have any.
What kind of services can you provide in your office? You mentioned that things that a primary care would do. I go to a primary care for a cold. What other things could I get from a primary care?
Yeah, I'm glad you asked that, and I should have brought that in earlier, because family physicians are trained to manage diabetes, to manage heart disease, to manage broken bones, to deal with depression, deal with anxiety, and hypothyroidism. Many of the things that your employees likely are going to specialists for today are being managed by the specialist office, because that's where the incentives are. Because you remember the primary care office, who was owned by the hospital organization, did not make money for the organization, but the specialist office does. So the job of the primary care office then is to get as many people out of the primary care office and into the specialist office. And it does so very effectively. And so many of the conditions that are commonly treated by specialists are done so just because the primary care doesn't have the time to do what they have been trained very well to do. And so, another example of a patient that came into our office, a 13-year-old boy had broken both of these bones. They were sticking out this way, not sticking out of the skin, but his hand is bent over this way, and that's something that almost always goes immediately to the emergency room. But I was able to get an orthopedist on the phone, and I said, okay, do we send him to the emergency room, or do we send him to you guys? And he says, yeah, we'll take that directly to the operating room. And I said, okay, well, cost is going to matter here. Can we get an estimate of the price? And he says, yeah, it's going to be $17,000 for this operation at least as a baseline. It may be more, but that's sort of the minimum. And I said, well, would you be able to at least try and set the bones without taking him to surgery first? And he said, yeah, we can try that. It's going to cost an extra $700 for us to try that, and there's a pretty good chance it's not going to work. And now you're looking at, you know, closer to an $18,000 bill, and we just wasted that money. And I said, well, okay, I set these in the emergency room, you know, if we're going to manage this case together, would you have any problem with me making a primary attempt at setting it here? And he said, oh no, that's perfect. You know, I'll walk you through it right now. And so we did a local injection for pain, which worked wonders. The 13-year-old didn't cry, didn't even flinch barely, we got his bones all straightened up. We splinted him, sent him for x-ray. Everything was perfectly aligned. We casted him, and I saw this kid about 3 months ago, and has perfect movement. Everything healed perfectly on this wrist, and the total cost of that fracture package was the cost of the 2 x-rays, which was at the time $35 a piece. So it ended up being $70 plus the cost of the cast, which was another $25. So under $100, he was able to manage his whole fracture. So that's just an illustration of many of the things that might be done in a specialist office today will likely be done in our direct primary care office with what I believe to be superior results.
So
Anything
what's the cost difference if you would have gone, obviously it's $17,000, $18,000, but if you would have had to go the traditional route, how much more expensive would that have been rather than you leveraging your relationship with that orthopedic?
Yeah, and that's where we get into a rough area. We were, in this case, able to find out that it was going to start around $17,000. But the rough part about insurance is you don't get to find out how much it's going to cost. You might get a basement estimate, but it could come back in anywhere in a $20,000 difference in terms of the total cost. And so, yeah, it's very hard to say with any individual case, but you can go with averages and say, you know, on average, you know, each case that we have like that is going to save you, the employer, $20,000.
So why, as an employer, am I buying insurance? What's insurance for?
Well, it depends on how much you need insurance to manage your risk. You know, a smaller employer like myself, we can't manage the risk of things happening to our employees by a self-funding mechanism. So if you have a large enough pool, then you probably don't need insurance actually to manage your risk, because when you have a big enough pool, the costs end up being, you know, within a range that your company can absorb. And at that point, you may not need any insurance besides maybe a stop loss plan to help you with some of the big outliers in cost. And it's particularly in those cases where a direct primary care might help you to save downstream costs, because it's all coming out of your pocket anyway. So you might as well manage the costs up front, and at the same time, you know, give much better care with better outcomes for your employees.
So, but what other providers do you have? Like, we have, you know, 60% of our force is female, and they want to see a female physician. Do you have options there?
Yeah, we have a female doctor and a female nurse practitioner and a female PA. So you got some options there, and we run out of 2 main offices, one in Peoria and one in Gilbert, but we also run pop-up locations in several of our employers on site. So we are able to bring the care right to the doorstep in many cases as well.
What does that look like? What can you do at a pop-up clinic?
Almost anything you can do at another clinic. You see Dr. Jeremy or Rebecca rolling in with their portable clinic, essentially with them, and they have medications and tools for procedures and things like that. They can get a lot done in those pop-up clinics. But if they unearth something that needs to be seen in one of our other clinics, then they'll at least be able to identify it on site and set up for another clinic.
If this works so well, why hasn't it taken off faster? Why aren't you 3 times the size, or why aren't all employers doing this?
Well, it's grown about as fast as I'm able to keep up with it. So I've been learning as much as I can about how to do it at scale, and that's been we're at a point now that we can take on an employer with 1,000 lives that we couldn't have done 5 years ago. So that's part of it, is the infrastructure in clinics like mine have needed to scale up. And now that we have a real executive team that's helping us keep the operations consistent and smooth throughout our clinics, then that gives us the ability to take on patients faster now. But that's been probably one of the major things holding us back, is being able to the direct primary care is now just here, I think, in that sense. But also on the employer side, what I sense is it's like many other things that are obviously good, especially in hindsight, but harder for people to be the first one to take the leap. So we have 20-something employers here in town that have been courageous enough or smart enough maybe to see that this is going to be good for their employees and their business. And I think many others just are now following to seeing now that their friends are having success with it. So I think you'll see a big wave of it as these early success stories spread throughout the community.
How do you know when to go to a DPC or when to go to like an emergency room? Broken arm, I would have thought emergency room right away. Is there certain things that you say, if it's this, definitely go to the emergency room? Yeah,
the easiest rule of thumb is if you think you might die, that if you don't get this taken care of quickly, then you should go to emergency room. If you're not sure, you can call us while you're on the way to emergency room. If you think that this needs to be taken care of soon, but you don't know where it needs to be taken care of, you call us. So really it's in those situations where you're afraid that this could get worse too quickly to even call us, that you end up going straight to the emergency room without connecting with us. But we have met patients in the ER parking lot before and determined that they actually didn't need an emergency room visit. That's a rare occasion, but it has happened, and helped people to avoid an ER. And sometimes an ER is exactly where you need to go. And having done ER work myself, I feel pretty confident about when those times are.
So do you work with employers that help create that culture shift? Because it's a big change for employees, I'd imagine.
It very much requires an employer who cares enough about their employees to help them understand what's going on, and is investing in this part of their business. It is an investment in the infrastructure of the employee benefits arm of your business, just like you might invest in a marketing team or invest in better infrastructure for your finance. We haven't been doing that for our healthcare team because we've just been giving all that money away without any control. But now many employers are taking control and investing in that arm of their business and growing it into a value center for their employees.
Can you describe the process? Like, our renewal is 11/1, but this sounds really good. Do I have to wait till open renewal or open enrollment? Can I do something now? How big of a process is this to get started? Because not only do I have to talk to my team about it, but I've got to bring this new person from the outside that they don't know that's wearing scrubs.
Yeah, which is always weird when I walk into any employer wearing scrubs. They're like, unless I'm in a hospital or a healthcare setting, people are like, what is he doing here? But to answer the first part of your question, do I have to wait for open enrollment to install some of these things? And no, open enrollment is an insurance construct that says you can only get in at certain times because we don't want you opting in when you need to manage a certain situation. That's not the case here. You're able to enroll in direct primary care at any part in that cycle. So we do have some people who will put it in right in the middle of the year in order to just start getting ahead of some of the downstream costs. And in terms of process, it's certainly something that you are going to want to talk through with a benefits advisor that is forward-thinking. There's only a few here in town. That may be another important point on your last question about why more people aren't doing it. More people aren't incentivized to do it, and so there's only a handful of benefits advisors here in town that have any experience with a direct primary care plan and are willing to do the work to help you invest in your company.
My head was going to, it sounds like a lot of work, but I don't know how to ask the question that I want to ask.
How much work is this for my team?
Well, it's more work on the front end than it is just signing a new contract. I don't know how much the work of your team is worth to you, but when you contrast that with the downstream costs of ever increasing healthcare, then this is the kind of work that I see as investment, as opposed to lost revenue or just straight expense. So yes, I would say there is more work on the front end than just signing a contract. There's work in educating your team, but it's the kind of work that I think your team will feel good about. Like we mentioned, or we saw with the employer who did this with his team. He was very happy a short ways into this with the investment that they made, so I think it's the kind of work that people enjoy doing. It pays off.
If you're on site, then do they come to you for low back injuries and workman's comp stuff too?
They can. That's something that we can talk more about. But in general, you would expect to see decrease in workman's comp as well, as people are getting better access to care early on before things turn into bigger problems.
That was a good question, right? You've mentioned cost savings for the company, but what sort of benefits can my employees expect outside of what they're kind of used to today?
Yeah, well, I think you're going to hear a whole different experience from your employees when they come in to get care. We we just ran our NPS score. It's 97 for this last year. 650 participants said it's 97. So so that's an indication to me that that people are just very pleased with the kind of service they're getting. We're getting comments like, "I had no idea healthcare could be like this. This is the best healthcare I've ever had." And there's lots and lots of comments about the care and compassion that they feel from the staff. And part of that, I think, is that we have created a team based on a defined set of core values. But I think also part of it is we have a structure that allows us to care. We have the time to show you that we care, and we have the time to not get so burnt out that we stop caring. So I think that's some of the main things that you're going to experience, as well as being able to get in to see us same day or next day for urgent needs, to be able to spend an extra half hour with us when you need to in the office, to be able to contact us by text message or by phone or video chat. Those are some of the things that people really seem to love.